suddenly there's a lot more blood flow to the brain. And then, but ACTA2 mutations, I forgot to mention this, are a very rare cause of moyamoya disease in the general population. And then we have this other gene, RNF213, and we think Asian moyamoya patients should be checked for this particular variant that's occurring in Asians and people of Indian descent from India. And the question is, should we sequence all moyamoya disease patients for alterations in this gene? And we should have an answer in the next year or two for that. Okay, so that's the genetics. Okay, now I'm going to switch gears and talk about, okay, we have these genes. What can the genes tell us about what's causing the disease? And I'm going back to this picture where this whole part should be completely open, and instead there's cells that have markers for these cells in the wall. So we think these smooth muscle cells in the wall of the artery are growing too fast or proliferating, and that they proliferate into the inside of the artery and occlude the artery. Okay? So if you look at moyamoya disease patients, this is what you see in those arteries. This is what we call the pathology associated with the disease. Is there a question in the back?
Is that just if you have a gene, or like?
So yeah, so we can't do this pathology on all patients with moyamoya disease because they don't take the disease artery out. They bypass it or they do other neurosurgical procedures. So all we can do is look at the artery in people that have actually died of moyamoya disease. So what you find is changes like this in people that have, where we can actually look at that segment. And so it doesn't matter what gene is altered, this is what the pathology looks like. And that's very common for diseases, that there can be a lot of different genes that cause a disease, but ultimately they feed into one pathway leading to that disease. So that if you look at something like Alzheimer's disease, lots of different genes can cause it, but they all end up with the same changes in the brain and decreased cognitive function as people get older. Okay, so once again, we're very interested in these, go ahead and hit it again, these smooth muscle cells, and whether we want to figure out if that's actually the cause. Is it that there's something wrong with these smooth muscle cells? So next slide. And I'll be giving out many of these slides and providing them to the website. Okay, so we wanted to look at our patients with these ACTA2 mutations, okay? And what is going on with their arteries. So we looked at some of the small arteries that we could get access to in patients with ACTA2 mutations to say what is going wrong with these arteries. So here's somebody that doesn't have an ACTA2 mutation, and these little things here are arteries on the outer layer of the aorta. So these patients have aortic disease, they go to surgery, we get the aorta, and so we can look at those arteries in those patients. And here you can see the arteries open and the wall is very thin, the area around the outside of the wall. And the red stain is for smooth muscle cells, okay? So here's two patients with ACTA2 mutations. And instead of these arteries being small, they're much bigger and often just totally occluded. And then and if you look at this under a microscope, you can see that there's a lot of cells there, and they're all staining for smooth muscle cell markers. So in this case, once again, it looks like that moyamoya disease, that the artery is getting filled up by these smooth muscle cells, suggesting that they are growing out of control. Just like in cancer, the cells grow out of control. And the same was true in another patient. So we just asked a simple question, if we take the smooth muscle cells, so we can take a piece of somebody's tissue and take it into the lab and actually grow smooth muscle cells from those patients in the lab. And so in the next slide, we took the cells into the lab from people that had their aorta removed but didn't have alterations in this gene. And then we took patients with alterations in ACTA2, took their smooth muscle cells, put them in culture, and just said, which one grows faster? And we can do this using assays in the lab. And so this is just a marker of how fast they're growing. And here's a bunch of control cells, and here's a bunch of patients with ACTA2 mutations. So where are you going? So right away you can see that the smooth muscle cells in these patients are growing much faster. So we don't have a lot of smooth muscle cells from patients with Moyamoya disease, but we can go and do skin biopsies on patients. A lot of patients with, we don't have a lot of smooth muscle cells from the aorta from patients with ACT2 mutations. But we can do skin biopsies and grow out cells in the skin that are like smooth muscle cells. So we did that. We took a whole bunch of patients with ACT2 mutations, and I went and did small little skin biopsies about this big. It doesn't hurt at all because I anesthetize the skin. And we put them into culture and said, do those grow more rapidly? And once again, these cells in the skin in patients with ACT2, they just grew faster in the lab, suggesting. And so if you take normal cells from the brain and you take brain cancer cells, you would see this same thing, that the brain cancer cells grow too fast. So this is looking like the tumor cells are acting a little bit like cancer cells, including the artery. Okay, so we can't do studies in humans, so we've set up an animal model of alterations in the ACT2 gene. And so we can take these animals and take their arteries out and grow smooth muscle cells much easier than we can from humans. And once again, when we did that study from a normal mouse and a mouse with changes in the ACT2 gene, we could once again, the smooth muscle cells from the animal model grew faster. So we take animals that have alterations in ACT2, and if we put their smooth muscles in culture, they grow much faster than mice that don't have alterations in that gene. Well, you know, we have a lot of drugs for cancers now, a lot of drugs for cancers. So we tried to figure out why these were growing faster, and it told us that one particular factor was driving these cells growing too fast. And because they're developing so many cancer drugs, we could take that drug and actually see and take a drug that was being developed for cancer and actually put it on our cells and say, does it cause these cells to grow like the normal cells? And when we gave them the drug, it decreases the growth of the normal cells, but it really decreases the growth of the mutant cells, or the cells with the ACT2 alteration, so that there's little to no difference between the rate that they're proliferating, okay? And so we wanted to say, so we can decrease the rate these cells are growing in the lab, can we actually do it in the animal model? So we can actually, through doing an injury of the artery, cause the cells to overgrow in the artery. So these two are from wild type or normal mice. These are two that have this alteration in the ACT2 gene. So we make a little injury to the artery, and in wild type, the wall gets thicker, but you can still see the lumen. But in the mutant mouse, it gets filled up with smooth muscle cells inside the wall. But then if we give these animals the drug, it kind of blocks that, even some of the proliferation in the normal mouse, but it completely blocks that proliferation in the mutant mouse. And this is a dose, we took the dose they use in humans to treat cancer. This drug that we're using is actually being used to treat cancers. It's very successful for treating multiple cancers, has very few side effects. It's being given to children with cancers and has few side effects in children. And people can be on it for years and years to control their cancer, okay? So we actually, for these studies here, we took a dose that was 1/10 what they use in cancer to treat humans with cancer. And that's what because the smooth muscle cells are not cancer cells. They're just growing too fast. It's not like they're growing wildly out of control. It's not like you have, you know, them taking over the body like you do in cancer and, you know, going to other places and growing. It's just that they're growing too fast right in that artery. And the blood goes right through the artery. So we thought if we could just get a very low dose of this cancer drug in, 1/10 what they use for cancer, could we block this proliferation? So we did this study with just almost a whiff of this anti-cancer drug, and it completely blocked the proliferation. Yeah?
Does it look like if you've gotten the diagnosis and you already have the occlusion, that it will,
Reverse it?
yeah.
Great questions. That's what we're doing next. So that's what we want to ask next. Okay? Excellent question. And before we take this into clinical trials in humans, we have to answer that question. So in the back?
Is it a specific cancer drug, anti-cancer drug?
It's a specific anti-cancer drug, and I intentionally just put drug up here because I didn't want all of you running to your doctors and saying, I'm going to be treated with this drug. So that is intentional. Until we have clinical trials in humans that it works, I don't want everybody talking to their doctor about this. And so I'm a member of the International Pediatric Stroke Consortium, and Heather Fullerton and other pediatric neurologists that you all may have interacted with are part of that consortium, and we're in discussions as to when do we take this into humans and when do we do the clinic, how much data do we need from the animal model before we take it into humans. This drug is already approved for humans, so that's the first step, and that's really good news. And there's many questions. Is it only going to work in patients with ACT2 mutations? I'm going to show you data in just a minute to say that it probably will work in patients with neurofibromatosis also. And then will it work in patients with RNF213 alterations? We don't know that. We just don't have an animal model for those particular alterations. Yeah?
When you take it to clinical trials, will it matter whether the person had surgery already or not?
No, so what we talked about was that, so you always want to compare your drug to the current therapy. Okay, so we thought that the way this clinical trial would be set up, that people would go ahead and have the normal treatment, and then after they've recovered from the surgery, we'd start them on this drug at very low doses to see if the artery would open up, because they get the imaging anyway after surgery. We can just follow and see if the artery that's already occluded, if the evidence that it opened up. But we want to, in our animal model, what we want to do first is make these occlusions and see if we can make them go away with the drug, okay? But then if we can put people that are, if we know who's at risk through the genetic studies, then it may be that we put them on just a whiff of this drug, starting young to prevent the disease too. And like I said, people can be on this anti-cancer drug. It's not like, some of the very bad drugs in the past where people lost their hair and so on. This is a very targeted molecular drug that people can be on for years and years to control their cancer. Yeah?
Do the drug reverse the effects, or
No, that's what we have to do next in our animal model. And so what we're working on that now, and we should have an answer in the next 6 months to a year. And at that point, if it does reverse the lesions or this blockage in these arteries, then I think we're ready to go to clinical trials in humans.
So this is like before the effect started?
Yeah, so when we injured the artery, we started them on this drug. Yes?
My brother had his heart attack when he was in his 40s. I had my first heart attack at 53 and my second heart attack last October, and I've got a triple bypass. After your clinical trial, after your clinical trial, would you suggest that I might need to be checked for the ACT2 mutation?
Can I talk to you afterwards and get the full family history?
But somebody like that might be a candidate for this drug.
Right, exactly. And then the other question is, could it prevent the heart attack?
Yeah. And would a condition that basically results from the proliferation of skin cells also possibly be another indicator that might indicate, some kind of condition? Because I have literally hundreds and hundreds of skin tags. It's been a problem that I've...
Why don't we talk about that? Yeah. That's a very interesting question.
Yeah. Okay.
Yes?
The trials, human trials, that you may not know this yet, would the people who had not had the surgery but had the diagnosis be candidates for that trial or not?
Probably not initially. Probably we'd want to go after those So once again, when you're doing clinical trials, you
Yeah.
want to compare your therapy to the standard treatment.
Yeah.
And so if somebody's having symptoms and we know the surgery works, and that's the standard, and it would be unethical for us to try these drugs and
Yeah.
without knowing that they
surgery,
work.
yeah,
So that's why we've set it up where they go to surgery, then we can use the drugs second after the surgery, is what we're discussing. I'm not sure exactly how it'll be set up, but that's the way we're planning it
That
right
answers
now.
my question.
Yeah,
You
yes.
talked about the proliferation of the smooth skin cells, and then you talked about vascular disease. Did you look at any other vascular anomalies? Like, my daughter had cervicofacial hemangiomas, and she had extensive, and then my son has Moyamoya disease. And one doctor told us there could possibly be a connection, or because basically what the hemangiomas does is that, there's accelerated
Right.
vascular cell growth.
Right.
Also in her head, it was extensive throughout.
Right.
And
right.
so I just wondered if you've seen any of that.
I don't know if we've seen that pattern in family, but I think you're asking the right questions. We just don't know the answer yet. But so one is overgrowth of actually arteries during development. So that could be the same gene, but right now we just don't know that. Yeah. Yes.
Considering that you would want to do the study on someone who's already had the surgery, would a candidate that's had surgery on one side but has the beginnings of it on the
That's
other
a
side?
great question. These are things we're going to have to, this is when you get everybody in the room and you hash out how to do the study. And so I think that's a great question, because if we do it on people like that, we can actually see
prevent having
if
to have
it
a second
prevents it
surgery.
on the unaffected side, or if it causes regression of lesions on the side that doesn't undergo surgery. Yeah.
In your study, did you see any relation between moyamoya and autoimmune diseases?
So autoimmune diseases often cause the blood to clot too rapidly, and that can also cause occlusion of arteries. And so I think having an autoimmune disease is a risk factor for having occlusion of arteries, and so there may be some interaction, but we haven't specifically looked at that yet. But I think it's a great question. And just in the last few minutes, I'm going to talk about, could this drug be used for other genes that cause Moyamoya disease? So is this something we could use for other patients with Moyamoya disease? Well, other groups have looked at the vascular disease in neurofibromatosis patients. And if you look at an artery in a patient that has an occlusion with neurofibromatosis, once again, here's the wall out here. This should be completely open and it's filled with cells. And the cells are marked by these dark stains, okay? So their arteries look to have the same type of lesions. And the gene that causes neurofibromatosis and the Moyamoya disease also predisposes these patients to having cancers and multiple different types of cancers. So other people have made neurofibromatosis animal model, and this work had been done, has done like quite a few years ago, but not really associated with Moyamoya disease in these patients. So they made the animal model and they looked to see if the cells grew more rapidly, and they did, just like we found in the ACTA2 cells. And then the next slide, they did the vascular injury. So here's the wild type, and here's the neurofibromatosis animal model. So here, after injury, this is what the artery looked like in the normal animal. And this is the neurofibromatosis animal, and once again, it's totally occluded. And then when they use markers for smooth muscle cells, those cells in there mark positive for smooth muscle cells with the brown stain. So they actually looked to see whether they could prevent these lesions using the same drug that we used. I don't have the data here, but they had the same results, that it prevented these lesions completely in this neurofibromatosis mouse. So once again, the same drug could potentially be used in patients with neurofibromatosis. And so I'm thinking that there's a possibility it'll reach across to be applicable to all patients with Moyamoya disease for reasons involve cellular biology, and I won't go into right now. But that's the hope, okay? So if we can show it works for patients with neurofibromatosis, in patients with alterations in the ACTA2 gene, then maybe we can take it into a clinical trial for oral patients. So that's the direction we're going. So just to summarize everything, we think there's lots of genes that